My question to Professor Sheth is, I can understand because of paucity of time he has to hush up. You have shown 3 formulae for estimating eGFR, and there are many more. I want to know which is the best. Please elaborate.
Yes, as I said, CKD epidemiology formula, which is estimating both creatinine and cystatin C. So eGFR based on creatinine and cystatin C is the best formula across all modes of GFR. There are limitations with MDRD and Cochrane and Gold below 60 ml GFR, which is not so with CKD epi formula.
Sir, even
it's
with
very easy to do this in a matter of less than a minute by feeding the values on a laptop or a
even in extremes of age and weight.
Yes. This has got that is the important best value of the CKD epidemiology collaboration. They have taken normal people, diabetic, non-diabetic, amputees, non-amputees, transplant kidneys. So many variables are included that across board, all board, this is reliable.
Thank you, sir.
Can I ask a question?
Yes, sir.
My question is to Dr. Sheth. Now, see, we are realizing that non-albuminuric diabetic kidney disease takes a very big proportion of patients. So my question is, because albuminuria means there is a glomerular disease, and if you take non-albuminuric diabetic kidney disease, the advantages of SGLT2 inhibitors will be seen in them also, or it's only limited to the patients who have albuminuria? As we saw that in ACE inhibitor, the major advantage only comes when there is albuminuria. So is the SGLT2 inhibitor also have the same limitation?
Extremely good question, Dr. Sushil Jindal. I mean, this is probably the best question that has been raised to me. Rector Brenner, the Bible of Nephrology, says that 40% of kidney disorders, diabetic kidney disease, is without proteinuria or albuminuria. When I was a student, I said, when you label diabetic nephropathy, as we used to call it, it is all because of proteinuria, diabetic nephropathy. But now we know that there is ischemic, there is drug-induced, contrast-induced renal damage or involving interstitium and tubules, which does not produce albuminuria or proteinuria. And this is sizable. This is almost 30 to 40% of diabetic kidney disease. And if we have changed the terminology from diabetic nephropathy to diabetic kidney disease, because 30 to 40% do not have proteinuria and albuminuria. And your second part of the question is again very interesting. Now we know from DAPA CKD trial, wherein we have gone right as down as 20 ml GFR and probably even up to 15 ml GFR, or if you have a residual renal output, I have given when the patient has reached dialysis. And it is found to be beneficial in diabetic and non-diabetic kidney disorder, in proteinuric and non-proteinuric kidney disorders. So this is the outcome of DAPA CKD trial, that even non-diabetic kidney disease, even non-proteinuric kidney disease also gets benefited. And we know that one factor benefit of SGLT2 is by hemodynamic benefit by afferent arteriolar constriction, reduces intraglomerular pressure. But there is another very important benefit is less oxidative damage, because most of the oxygen utilized by kidney is by the proximal tubule. SGLT2 blockage saves so much of oxygen requirement of the kidney that 90% of the oxygen is utilized only by SGLT2 receptors. So that is an excellent benefit to tubular interstitium beyond glomerular benefit. So SGLT2 on all account beneficial in all the patients.
Thank you, sir. Thank you.
Hello, my one simple question to Dr. Panikkar.
Yeah.
Regarding the glycemic control, is there any cutoff for the glucose variability in terms of time in range in any guideline?
Not really. But now with the continuous glucose monitoring, which is available even for the patients, I think a lot of data would get generated slowly. But ultimately, it's a good glycemic control which matters. And once you have a good glycemic control, I think 9 out of 10 times glycemic variability is also taken care of. The glycemic variability
cutoff. No clear-cut cutoff is there.
No, not that I know of. Sushil, is there anything?
Regarding
Glycemic variability.
See, this concept I think was brought in more and more because we have some drugs which can have a smoother glucose control, and then I think it is overemphasized. Only thing is we should avoid hypoglycemia, which is more important. But yes, there are some drugs which will not produce day-to-day or intraday variations. But this is, I think, in my opinion, it's overemphasized. only thing to see is that we should avoid hypoglycemia at all costs.
And another simple question is, will there be any benefit or is there any cutoff criteria in the different age groups for glycemic control? So it is there for the older age group, geriatric, but is there any adolescent, adult, pediatric?
No,
Should
see,
there be
basically,
cutoff? I have not.
no, basically the rule, the standard thumb rule is younger the patient, tighter the control, older the patient, less relax the control.
Yes.
That would be the just simple guideline.
But for very young children, sir, again these rules goes away. For
I
very
think I
Yes,
can add
yes,
some,
yes.
I can add
Yes, Bansi,
something.
you're right. In pediatric age group, type 1, it is difficult to get a tight control because they're
but
kids.
the target is less than 7. Dr. Sushil Jindan wants to make some comment. Yes, doctor.
Yes, sir. Actually, what is said in the earlier textbooks was that at prepubertal age, the body can tolerate hyperglycemia very well. And so in some guidelines up to 3 years back, it was said that for type 1 diabetics, you can have a relaxed sort of a HbA1c cutoff, particularly if the patient is in the prepubertal age. But now the latest guidelines say that even for the children, you should aim for tighter control because in the long run, this earlier hyperglycemia can produce complication at the later age.
Sir, is there any role in using fructosamine anywhere instead of HbA1c? Indication, if any?
I think pregnancy is one of the best indication because because of hemodilution, the values of HbA1c gets deranged. So fructosamine will tell you better.
I mean, but the problem.
Thank you, sir.